What is up? Perfect. That's not what I wanted to do. Look, need to. Here in my video, that's what it is. Sliding is weird. Maybe it's that. Now I'm actually have to turn on the big light. There we go. Let's turn those off. All right. All right, we're just going to go ahead and jump in, and as people join, they will join. So we're going to start with our 5 musculoskeletal questions. And what you're going to see is that each one kind of goes through each domain of the NPTE questions. So let me get this a little closer to you guys. So it's going to go through each domain of NPTE questions. So the first one is going to be examination. And then we'll go evaluation. I believe it's differential diagnosis, then prognosis, and then intervention. So we're just going to go ahead and jump right in. A patient presents with lateral elbow pain aggravated by gripping and resisted wrist extension. Which special test is most appropriate to confirm suspected diagnosis? Okay, so let's just go ahead and highlight what we think is important. They've got lateral elbow pain, so this is the location. Aggravated by gripping and resisted wrist extension. Okay, which special test is most appropriate to confirm the suspected diagnosis? Valgus stress test, A, B, Cosen's test, C, Phelan's test, or D, or sorry, yeah, C, Phelan's test, or D, Tunnel's sign at cubital tunnel. So really, the key to answering this question correctly is just being able to know what each special test is for, right? So let's just jump right into valgus stress test. We know is going to test the integrity of the medial collateral ligament, right? And so is that, or does this reflect a medial collateral ligament sprain? So we've got lateral elbow pain, maybe, or sorry, no, this valgus would be medial stress test, right? Gripping resisted wrist extension, no. I'm not thinking medial collateral ligament at all because first of all, it'd be medial elbow pain, right? So I'm going to say not A. B, Cosen's test. So Cosen's test is a test for lateral elbow pain, so like tennis elbow. Phelan's test is test for carpal tunnel syndrome, right? And then Tunnel's test is, again, at the medial elbow, at the cubital tunnel, that's checking for ulnar nerve involvement. And so Cosen's test is the one that seems the most appropriate since based off of this, we're getting probably a tennis elbow kind of feel, right? So the answer to the first musculoskeletal question is B, Cosen's test. All right, let's go ahead and we'll, if there are no questions about that, if there are, you guys just start putting them in the live and then, or put them in the comments and then I'll answer any questions. I'll try to give you guys a little bit more time on these next to answer some. You are not late. We just got started. So this is just question number 2. I was saying earlier that we're just going to jump right into the musculoskeletal questions. I've got 5 musculoskeletal questions to start, and then we'll do 5 cardiopulmonary questions at the end, okay? So, the evaluation musculoskeletal question. A patient has full passive knee extension, but lacks 15 degrees of active knee extension following ACL reconstruction. Quad strength is 3- out of 5. What is the most likely contributor to this limitation? A, capsular tightness, B, hamstring contracture, C, quadriceps inhibition, or D, patellofemoral joint restriction. All right, so again, let's pick out the stuff that we think is important. Actually, you guys go ahead and answer what you think it is, and then I'll pick out what I think is important based on this, okay? So I'll read it one more time. A patient has full passive knee extension but lacks 15 degrees of active knee extension following an ACL reconstruction. Quad strength is 3 minus out of 5. What is the most likely contributor to this limitation? A, capsular tightness, B, hamstring contracture, C, quadriceps inhibition, or D, patellofemoral joint restrictions. So go ahead and lock in your answers in the chat, and I will go through what is pointing to the right answer here when we pull out stuff from this question. Okay, look, Northgate Nightmare and Labs has answered, Gatsby's answered, Life of Geo has answered, Trent SPT, it's good to have you in here, man. You guys go ahead and read over the question as you kind of come into the group, and then we will go over here in just a second. Sandwich has answered. Okay, so let's go ahead and pull out the important information. He has full passive knee extension, okay, but lacks 15 degrees of active knee extension following ACL reconstruction. Okay, quad strength is 3 minus out of 5. All right, so let's just go over what we know about passive versus active range of motion and all of the answer choices. So if there was capsular tightness, if that was what was restricting him from being able to move into 0 degrees of extension, then we would not expect passive knee extension range of motion to be full, right? So already I'm thinking it can't be capsular tightness. So hamstring contracture in the same way. If there was a hamstring contracture, passive motion should still be limited, right? So it can't be hamstring contracture. Also, I mean, it doesn't say how long this person is post-op, but it would take a long time to develop a hamstring contracture, right? Like a legitimate contracture. Quadriceps inhibition, well, we know that it's 3 minus out of 5. They're post-op ACL, so if they're having a lot of pain, especially with active knee extension, then it could be that we're getting that inhibitory response as a response to the pain. So that's not a bad answer. That's looking pretty good. And patellofemoral joint restriction. Well, if there was patellofemoral restriction, because the patellar tendon is going to be more stressed in flexion and less stressed in extension, I would be shocked if patellofemoral joint restriction led to a lack of knee extension. I would expect patellofemoral joint restriction to lead to a lack of knee flexion, okay? So I'm going to say not D. So that leaves us with the answer C. So just remember, anytime you're post-op, if they're still having a lot of pain, then anytime that our bodies are trying to actively move through pain, we're not going to get full strength because our brain is like, dang, that hurts. So it's going to inhibit the muscles that are firing, right? So everyone that said C, good job. Let's move on. Does anyone have any questions about that one? I'll give you guys a few seconds in case you want to type in a question. Dropped into flex. See you guys. Dropped into flex. See you, Life of Geo. Okay, let's just move on to the next question. Differential diagnosis of musculoskeletal system. A 55-year-old reports shoulder pain, worse at night, and weakness with abduction. Passive range of motion is full, but painful at the subacromial space at end range. Active range of motion is limited and painful. Which diagnosis is most consistent? A, adhesive capsulitis, B, rotator cuff tear, C, glenohumeral joint osteoarthritis, or D, cervical radiculopathy. You guys go ahead and put your answers in the chat. I will read through it one more time. A 55-year-old reports shoulder pain, worse at night, and weakness with abduction. Passive range of motion is full, but painful at the subacromial space at end range. Active range of motion is limited and painful. Which diagnosis is most consistent? All right, good job, guys, answering. I appreciate. I'll give you guys just a little bit longer, so anyone that wants to drop in answers real quick can. All right, let's go ahead and pull out the important stuff, right? So shoulder pain, worse at night, weakness with abduction, okay? Passive range of motion is full, but painful at the subacromial space at end range. Active range of motion is limited and painful. Which diagnosis is most consistent? So we can either say that passive range of motion is full in all directions because they didn't really specify which, like in what directions, or because they mentioned abduction, you could also, like, perhaps it could be suggesting like passive range of motion of abduction. But regardless, what we know is that they got full passive range of motion, right? But painful at the subacromial space at end range. Active range of motion is limited and painful. Which diagnosis is most consistent? So, if this was adhesive capsulitis, passive range of motion should be painful, like through all of it. And I doubt it would be full because what we know about adhesive capsulitis is that pain is in the early stages of adhesive capsulitis, pain is greater restriction than actual joint capsular tightness or stiffness. And then in the middle of it, as it's like after it's done freezing and it is frozen, pain and range of motion are limiting factors. And then in the final stage, as it's thawing, pain is not a limiting issue. It's just capsular range of motion. And so at no point in adhesive capsulitis would I expect passive range of motion to be full. Because it's inflammation of the capsule itself, it should be painful with passive range of motion because passive range of motion will get pain in the inert tissues, right? And so I'm going to say no to adhesive capsulitis. B, rotator cuff tear. So we know that they've got weakness with abduction. Worse at night. Any kind of inflammatory response is going to be worse at night. It's the same reason that our throats, like when we're sick and our throats are sore, our sore throat is worse at night. It's just because as our body cycles throughout the day, nighttime is going to make inflammation worse. And so passive range of motion is full. Okay, that would be expected with a contractile injury, right? But painful at the subacromial space at end range. So going up, yeah, you might just still get some pinching in that subacromial space as you take them to end range. And then active range of motion would be limited with a rotator cuff tear, right? And it could be painful if it's not a full tear. So that one's looking pretty good. Let's go ahead and look at the rest. Glenohumeral joint osteoarthritis. Well, we know that osteoarthritis produces a capsular pattern, and they're saying that, so capsular pattern of the shoulder is external rotation is greater than what? External rotation is limited the most, and then what's second most limited? Abduction or flexion? Anyone know? Hey, nice, very good. Abduction, good job, guys. Okay, and then internal rotation. I like Mahai. Is that your name? I like your. Yeah, you guys have a good mnemonic there. ER, abduction, IR. So, so because it's saying that passive range of motion is full, I don't exactly expect osteoarthritis to be an issue. I'm just kind of picking out a couple things that would immediately make me think not that, but with glenohumeral osteoarthritis, I wouldn't necessarily expect only weakness into abduction, right? I mean, if glenohumeral osteoarthritis is causing enough inflammation that pain is limiting, I would expect it to be limited in all motions, right? Not just abduction. So I'm not thinking glenohumeral joint osteoarthritis. And then cervical radiculopathy, I would expect it to talk about radicular type symptoms, numbness and tingling, weakness of the hands, things like that. I wouldn't expect that to be localized to the subacromial space, right? So I'm not thinking cervical radiculopathy. So the answer is rotator cuff. Good job, guys. All right, so that was your differential diagnosis question. We're about to jump into the prognosis question. Do you guys have any questions about this so far? Or, I mean, any of the questions previously? I don't want to go back just because I don't want to end up going over questions multiple times. I want to make sure that we're still moving forward. But I will let you know, there was someone that was on live last week that told me he wasn't going to be able to come tonight. So if you guys are just joining, I will post pictures of these throughout the week, so that way you guys can still see what stuff we went through in case you missed any of it. So it was correct to associate this with painful arc, right? Yeah, I mean it should, right? So you should get painful arc because presumably, if you've got rotator cuff tear, you're not going to have effective um, like downward glide in the glenohumeral joint, and so you're probably going to get impingement of that supraspinatus among other tendons. And so, yeah, I would imagine that a painful arc test would be positive in this regard. But like I said, I will add photos of these unmarked on this week, so that way, if you guys didn't get to see any of the questions, you still have access to them on my TikTok page. Okay. Prognosis question. A patient with acute lumbar strain has localized pain, no radicular symptoms, and no prior episodes. What is the most appropriate prognosis? A, poor due to high recurrence. B, fair due to risk of chronicity. C, good with expected resolution within weeks. Or D, guarded pending imaging. Let you guys go ahead and answer your question. I'll read it one more time. A patient with acute lumbar strain has localized pain, no radicular symptoms, and no prior episodes. What is the most appropriate prognosis? A, poor due to high recurrence, like saying their prognosis is poor due to the high recurrence. B, their prognosis is fair due to risk of chronicity of back pain, of this type of back pain. C, good with expected resolution within weeks. Or D, guarded pending imaging. Okay, Northgate, Mahai, Lololo have all answered. Mahai, I hope I'm saying your name right, man. If I'm not, call me out in the chat. Trent answered. All right, let's go ahead and pick out the important stuff. So, acute lumbar strain. So, if they say strain, you got to automatically think muscle, right? If it says strain, we're not thinking discal pain, we're not thinking facet arthropathy, anything like that. And it's localized. So once again, wouldn't seem to be discal pain, right? Or discogenic low back pain, because that should not be very localized. No radicular symptoms. That's a good sign, right? Again, kind of confirming that it probably isn't like a lateral stenosis, probably not a nerve root impingement from a discogenic low back pain or hypermobility into extension, right? So really we're thinking probably just pulled one of their back muscles based on this information. So if they just pull the back muscle, what do we know about recovery of muscle strains, right? So I don't think it's A. One thing that should immediately stick out to you is that high recurrence, well, he has no prior episodes, so there's no recurrence up to this point, right? So there's no reason to suggest that he's had high recurrence of these episodes, right? B, fair due to risk of chronicity. Well, I mean, if we're talking about like arthritis in his low back, like there's going to be chronicity to that. Discogenic low back pain has a higher rate of chronicity just because we know that the scar tissue, once we centralize the disc and we allow time for scar tissue to go down, there's always the possibility of chronicity or recurrence of discogenic low back pain, because that scar tissue only has 70% of the integrity, right, of the initial tissue. And so it's possible that discogenic pain or arthritic pain would have some chronicity to it, but this is a muscle strain, and muscles recover really well, so I don't think it's B either. C, good with expected resolution within weeks. That seems like a pretty good answer. It's a muscle strain. If we treat it right, we let him rest for a bit and then just keep him moving in pain-free range of motion, right? And then as he can tolerate more and more of that movement, start doing some progressive resistance training. So that looks like a pretty good answer. D, guarded pending imaging. There's nothing in this that is throwing up any red flags that makes me think he needs imaging. Even if it said radicular symptoms and like diffuse pain, if it doesn't say anything about bowel and bladder, progressive bilateral weakness, or anything like that, I don't think he needs imaging. Like, if there's no red flags, then there's nothing to suggest that imaging is indicated, right? So I'm going to say no, especially just because we're talking about an acute lumbar strain, and we don't need imaging for that. It's not going to tell us anything we don't already know. So C, good prognosis for acute lumbar strain. You're still going, yeah, Austin, we just started like 20 minutes ago. I hope that you're able to join. I'm still going to post these like I told you that I would. I went ahead and took pictures of all of these questions unmarked. And so I'll post those probably tomorrow just as like pictures that you guys can swipe through. So I'll post the unmarked one and then I'll post the marked up one right after. Oh no, brother. I forgot to announce. I realized after I posted that video that I forgot to announce the time again. But if you guys are on right now, I'm making this a regular thing. We're 8 p.m. Central Standard Time on Sunday nights. We're gonna do NPTE night school. So I'll be here, even if no one shows up. I'm gonna go through these questions because I spent the time writing them. So, all right, dudes, guys, and gals. We're all dudes. Let's go to number 5. This is our last MSK question, okay? So, a patient with knee osteoarthritis demonstrates quadricep weakness and pain with stair descent. Which intervention best addresses functional limitations? A, open kinetic chain knee extension with resistance. B, passive knee mobilizations only. C, closed kinetic chain strengthening within pain tolerance. Or D, prolonged rest and activity avoidance. I'll read that one more time. A patient with knee osteoarthritis demonstrates quadricep weakness and pain with stair descent. Which intervention best addresses functional limitations? A, open kinetic chain knee extension with resistance. B, passive knee mobilization only. C, closed kinetic chain strengthening within pain tolerance. And D, prolonged rest and activity avoidance. Give you guys some time so you can submit your answers. If you guys get a second, I'd love to know. This is, I think I had like 8 to 10 last week. We're up to like 19. We're bouncing between like 18 and 21. If you guys would, just so I can know where you guys are coming from, tell me where you're going to PT school. I went to the University of Arkansas for Medical Sciences here in Fayetteville, Arkansas. And I had a guy last week who said he was tuning in from the Philippines, and another one that said he was from Vancouver. And so I'm just always kind of curious how far away people are that this is reaching. Hey, Philippines! No way! You're not the same person. You're not the same person that said that last week. Taking more boards in January. So this is good practice. Good. Good. From PH. Philippines, I guess. In Florida, Oklahoma City. Cool. Hey, my brother lives in Oklahoma City. Okay, let's go over this. Quad weakness, right? Pain with stair descent. The big thing you should have all picked out of this, which intervention best addresses functional limitations? His limitation or her limitation is they have pain with stair descent. Okay, so which of these is going to address the functional limitation? Raleigh in Hawaii, very cool. I'm from Mexico. Sweet. Man, you guys are from all over the place. That's awesome. I live in probably the most boring place out of all of us. 2 a.m. med call. Oh, dang. So, functional limitations. Let's just go over these. Which of these is going to help address their function, right? It's going to help promote and simulate their function, right? Open kinetic chain knee extension with resistance. While this may be a good exercise, it's not going to be the one that addresses their functional limitations, right? Because open kinetic chain means they're not weight bearing. So, oops, I like the red markers for the wrong answers. B, passive knee mobilization only. Well, if we're only doing passive knee mobilization, we're not getting them to practice bearing weight on it or going through mini squats or step ups on a smaller stair or something within a pain-free range of motion. If we're only doing joint mobilizations, maybe it'll reduce their pain, but it's not necessarily going to carry over to function, right? So, not B. Closed kinetic chain strengthening within pain tolerance. That sounds pretty functional because they got to put their foot on the floor and we got to practice some stuff that's going to take them through some closed kinetic chain range of motion, just like they're doing when they do stair descent, right? Prolonged rest and activity avoidance. I hope we never tell any of our patients to do prolonged rest and avoid activities, because even if a person is non-weight bearing, we never tell them like, just lay down, right? Don't do anything, because we want to keep the stuff that they can move without bearing weight, we want them to move it, right? So I don't think we're ever going to tell a patient, like, don't do anything, right? I think it's C since it encourages strengthening since it must be functional. Yeah, totally agree with you, Lulu GB. So I can't think of a situation where I would ever tell a patient to just rest and don't do anything, right? Because that's just going to make them even more deconditioned. So the answer here is C, closed kinetic chain strengthening. Any questions about that one? If not, then we'll just go ahead and move on to the cardiopulm questions. Let me just briefly go back through these in case anyone had a question about the MSK stuff. Since we're going to shift to musculoskeletal, I just want everyone to get a second. So this one was a question about lateral elbow pain and which special test would help confirm the supposed diagnosis. Anyone have questions about that? Okay, we'll move on. This was the evaluation question about a patient who's lacking 15 degrees of active knee extension but has full passive range of knee extension, and just getting an idea of like which is most likely the contributor to that. Any questions about that? Give you a few seconds. Okay, I'll go ahead and move on. This one was about a patient who has shoulder pain that's worse at night, weakness with abduction, full passive range of motion, but pain at the end range, under the subacromial space, and active range of motion. And it was just asking about which diagnosis is most consistent. Just a little bit of differential diagnosis. No questions. Thank you for saying none, Lulu GB, just because I don't want to feel like I'm just wasting all you guys' time. Okay, this one was acute lumbar strain. Questions about what's the most probable prognosis. Any questions about that? No. Okay, and then we just went over this one, so we'll just move right on. Okay. So the cardiopulmonary examination question. Which vital sign finding would most strongly indicate exercise intolerance in a patient with heart failure? A, resting blood pressure of 130/85 millimeters of mercury. B, resting heart rate of 68 beats per minute. C, O2 sats dropping from 96 to 88 with activity. Or D, respiration rate of 16 breaths per minute at rest. I'll ask that one more time. Which vital sign finding would most strongly indicate exercise intolerance in a patient with heart failure? A, resting blood pressure of 130/85. B, resting heart rate of 68 beats per minute. C, O2 sats dropping from 96 to 88% with activity. Or D, respiration rate of 16 breaths per minute at rest. Go ahead and submit your answers. All right. I think so. Several of you. Yeah. It looks like a lot of you have gotten answers in. Anyone else got any answers? Go ahead and hit that button and we'll go over this. Okay, so the question is asking is which is going to tell us that we need to not do exercise or like stop exercise, right? So which of these vital signs is going to tell me like, oh, I should stop doing exercise, right? So a resting blood pressure of 130/85, sure, that's mildly elevated, but it's not like crazy, and it definitely gives me enough room to work with where like if my cutoffs are like 180/100, right? If that's my red flag zone, then we got plenty of room to work with because diastolic shouldn't rise that much, right? And that gives like 50 points of systolic before I'm like, we should probably chill. But if their resting blood pressure is 130/85, not really concerning to me. I'm not worried about them having a stroke. I'm not worried that they're in the middle of a cardiac event, anything like that. So this, I would say, is not going to strongly indicate exercise intolerance. So we'll say not A. Okay, the next one, resting heart rate of 68 beats per minute. We know that normal resting heart rate is between 60 and 100, right? So 68 at rest is actually pretty good for someone that has a presumed cardiopulmonary, like has heart failure, right? 68 is a pretty good resting heart rate. I'm not super worried about that. Actually, yeah, there's nothing about that resting heart rate that makes me nervous. C, O2 sats dropping from 96% to 88% with activity. That's pretty concerning. right? Because they have heart failure. We didn't say they have COPD, where 88% is like roughly, reasonable. You can eliminate anything that says resting. Yeah, good point. Respiration rate of 16 breaths per minute at rest. 16 is perfectly within the parameters of normal also, right? 12 to 20. I will say, user, the only things that would make me concerned about exercise intolerance, I might, like, clinically speaking, if I had a patient who I walked in the room and they were at rest and their heart rate was like 105, 110, I'd be like, I don't think you're going to respond well to exercise, right? If their respiration rate at rest is 30, then I'm like, you're probably not going to respond well to exercise. But all of these are within normal limits, right? And so I wouldn't. Now, that being said, you can't directly say, like, oh, well, that's an indication that they're going to have poor exercise tolerance. That would be yellow flags or red flags to me that I'm like, I'm not going to initiate mobilization at this time because they don't seem stable. So anyway, with that being said, C, if they've got O2 sats dropping by 8 points with activity and they don't have COPD, they have heart failure, right? That's a pretty big deal. I'm going to say they're probably not tolerant to exercise. So what does the book say? XYZ, blah, blah. Yep, this is MPTE style. You're right. I'm not trying to dog on you. But you're absolutely right. I mean, NPTE isn't going to try to trick you and be like, but clinically, what would you, right? They're saying, like, what do you know about what you learned in class, right? So you're right, user. You're right. All right, evaluation question. A patient demonstrates dyspnea at rest, orthopnea, and bilateral lower extremity edema. Which condition is most likely? A, COPD, B, pulmonary embolism, C, left-sided congestive heart failure, or D, right-sided congestive heart failure. Let you guys take your time. If respiration was 23 with activity, then which would be best? If respiration rate was 23 with activity, if it was with activity, then I'm not super concerned, right? I expect activity to make their respiration rates go up. So if they've got 23 with activity, then I wouldn't be super duper concerned about that either. Trent. All right, let me read this one more time. You guys go ahead and submit your answers when you're ready. A patient demonstrates dyspnea at rest, orthopnea, and bilateral lower extremity edema. Which condition is most likely? COPD, pulmonary embolism, left-sided congestive heart failure, or right-sided congestive heart failure? I got 2 people that have answered. I'll let you guys think a little bit longer. Also, just a note, I was at a professional conference. I was at the Academy of Neurologic Physical Therapy annual conference, and there was a person presenting that pronounced this dyspnea. Has anyone ever heard it pronounced dyspnea before? Because that totally threw me off. I've never heard anyone. That would be like me calling apnea apnea to me, or orthopnea, and I've never heard that, so it totally threw me off. No, yeah, me either. I was like, wow, that sounded super weird. Okay, so it looks like P is definitely silent. Dyspnea. What? What are you talking about? Dyspnea. That sounds normal, right? Okay, several people have answered. I'm going to ask you guys to flex a little bit. I don't want to explain this one to you. I want you guys to tell me. What did you pick out in this question that makes you think right-sided CHF? I'll wait until someone says it. I 100% will. Edema, okay. Bilateral edema, bilateral lower extremity edema. That's, yeah. So you're right, Northgate. I just want you to be a little bit more specific. It's bilateral low extremity edema. If it was left-sided congestive heart failure, I would expect them to talk about a lot more pulmonary issues like pulmonary congestion, pulmonary edema, things like that. So you guys are absolutely right. That bilateral lower extremity edema, and just know, orthopnea, we probably think of orthopnea a lot more with left-sided CHF, but it can still happen with right-sided CHF, right? With left-sided CHF, I would expect more like the paroxysmal nocturnal dyspnea, right? So like when they lay on their back and they like wake up in the middle of the night and they have to sit up, or stand up to catch their breath, things like that. They say sleeping in a recliner makes me feel better. I would expect that out of left-sided CHF. So it's more of the cluster of things like you guys just mentioned, and bilateral lower extremity edema. That's like 100% right-sided heart failure, because the right side of your heart, right, isn't doing enough to manage the venous return, and so it just gets backed up. And where is it coming from? Lower legs, right? So it's just getting swollen down there because the right side of the heart can't keep up. So it's not COPD, because I would expect like maybe dyspnea at rest, but I wouldn't expect bilateral lower extremity edema. I mean, it's a little bit of dyspnea. Dyspnea is kind of weird for it to be at rest, even with COPD, unless they're supposed to be wearing oxygen and they're not doing it. Pulmonary embolism, this tends to be more of an acute issue that can, I don't want to say too much about pulmonary embolism because I do have a question later that asks you to like do differential diagnosis between a couple things, and I think if I give you answers now, it may make it easier for you to rule in or rule out PE. Left-sided heart failure, we talked about the cluster of more pulmonary congestion and things like that, and so I wouldn't go with left-sided CHF. Okay. So let's move on to the differential diagnosis. A patient experiences sudden onset dyspnea, pleuritic chest pain, and tachycardia following prolonged immobilization. What is the most likely diagnosis? A, pneumonia, B, myocardial infarction, C, pulmonary embolism, or D, aortic dissection? Give you guys some time. I'll go ahead and read through it a little bit more slowly. A patient experiences sudden onset dyspnea, pleuritic chest pain, and tachycardia following prolonged immobilization. What is the most likely diagnosis? Pneumonia, myocardial infarction, pulmonary embolism, or aortic dissection? Give you guys some time. Go ahead and drop your answers in the chat. While you guys are doing that, it seems like we've had several more people join. I want you guys to know I go through 10 questions every Sunday. It starts at 8 p.m. Central Standard Time. It's my NPTE night school practice questions. Just so you know, we've already gone through the musculoskeletal ones. I told you guys in my video earlier that we were going to be doing Cardiopulm and MSK today. So we went through MSK with the first 5 questions. I will post pictures of all of these questions tomorrow on TikTok. They will be blank like this one is now, and then I'll have the very next picture be the ones marked up with the wrong answers X'd out and the right answers circled. Can you recommend me a PT book for Cardiopulm? It is included in my next semester. So, oh gosh, what is that woman's name? Give me a sec, I'll think of it. Oh my gosh. Give me a second, I'll think of it. Hillegas. Thank you. Yeah. Hillegas. That's what the school that I went to uses. They still use that for their Cardiopulm stuff. Hillegas, they use her a lot as a source for the Cardiopulm questions that they write. So on the NPTE. So I would just get a Hillegas book. She's pretty legit. Austin, I'm not 100% sure what you mean by normal chest pain. I wouldn't say that chest pain is particularly normal. So I would think I would need you to be a little bit more specific on like, what do you mean by normal chest pain? You know what I mean? Because if it's musculoskeletal and it's like joint related, then I would expect it to be super duper localized. If it's rib pain, like costochondral stuff, that'd probably be worse with breathing in and out. Pleuritic chest pain just means it's going to be derived from the pleura, like the pleural space, right? And so it's probably going to get worse with inhalation and exhalation and things like that. But I can't really give you that. I can't really give you that answer without like helping you rule out the other stuff. Sorry. We'll talk about it here in just a bit. Hillegas taught, yeah. Prolonged immobilization means day at dislodgement went to lungs, would be sudden onset. Okay, let's talk about it. So you guys are kind of already putting pieces together. So important stuff: sudden onset dyspnea, pleuritic chest pain, right, and tachycardia following prolonged immobilization. I'm going to go ahead and tell you pneumonia is rarely sudden on. It's usually a gradual onset, right? And so it might result in dyspnea, potentially result in tachycardia, but it wouldn't be sudden onset, right? And so I don't think it's pneumonia. MI can cause dyspnea. It can cause tachycardia for sure, but I wouldn't expect it to cause pleuritic chest pain, right? It's going to be more like chest tightness. A lot of people will say, like, I feel like an elephant is sitting on my chest, and then referral of pain up into your jaw or into your left arm, right, or interscapularly. And so it's not talking about pain in a way that I really feel like is typically associated with MI. Pulmonary embolism, well, we know that's obviously like the participant earlier was saying, sudden onset usually means that like a DVT has dislodged, right, and then has made its way up into our heart and then through the pulmonary arteries into one of the lungs, right? So pulmonary embolism is looking pretty good because it definitely would cause pleuritic chest pain, right? Chest pain in the pleural space, sharp, especially with breathing. And then aortic dissection would be sudden onset of pain, but it wouldn't be pleuritic, right? Aortic dissections are more of that like boring pain that probably spreads like really into your back. You probably would see tachycardia, but I wouldn't necessarily think dyspnea is like directly associated with aortic dissection. It can if you're trying to increase oxygen content, right? So that as you're bleeding out inside, the periphery of your body is still getting oxygen, but just the pain pattern, it doesn't make a ton of sense with aortic dissection. So I would say not aortic dissection. And the answer is, like you guys said, pulmonary embolism. You guys have any questions about that? If not, we will move on to question 9. Prognosis for cardiopulm conditions. A patient with stable COPD who has quit smoking and adheres to an exercise program most likely demonstrates which outcome? A, progressive functional decline regardless of intervention. B, improved exercise tolerance and quality of life. C, complete reversal of pulmonary impairment. Or D, no measurable benefit from exercise. I'll read it one more time a little bit more slowly. A patient with stable COPD who has quit smoking and adheres to an exercise program most likely demonstrates which outcome? A, progressive functional decline regardless of intervention. B, improved exercise tolerance and quality of life. C, complete reversal of pulmonary impairment. Or D, no measurable benefit from exercise. I see you guys, a lot of you drop in answers. Very good. I'm glad you guys are interacting. Okay, let's go ahead and go over it. So they quit smoking. Great. That's what we want all our patients to do, right? And they're adhering to an exercise program. So what do we know about when people eliminate the modifiable risk factors and adopt a regular exercise program? How do we expect their body to respond, right? Progressive functional decline regardless of intervention? No. I would only expect that to be the case if they were continuing to be sedentary and continuing to smoke. I would expect progressive functional decline, but not regardless of intervention. If they're intervening in a positive way, I don't expect this to be the case at all. The other one that we can pretty much immediately rule out is no measurable benefit from exercise. That's rarely going to be the answer, right? Unless we're talking about something that is not a PT problem. But that one should be easy to rule out. Usually on your NPTE, you're going to be able to eliminate 2 answers pretty quickly, and then you'll look at 2, and you have to pick the best one. So B, improved exercise tolerance and quality of life, or C, complete reversal of pulmonary impairment. So COPD does respond well to exercise and when we take away those modifiable risk factors that were making us more at risk of progressive dysfunction, right? But COPD does cause damage that is not totally reversible. And so it would not be complete reversal of pulmonary impairment. So the answer is, because we know that exercise can improve tolerance to exercise and quality of life. So very good. Anyone here taking January NPTE and want to study together? PT or PTA? PT? Yeah, there's several of you that I saw last time that are taking boards in January. So good luck, guys. I'm trying to gear my content that I post like daily or every other day towards what you guys want to, or what you're feeling like you need to brush up on in this very short time between now and when the boards are. So if you guys want certain content, if it's non-systems or other systems or MSK, cardiopulm, neuro, whatever, just let me know, and I'd be happy to come up with more and more questions um, that are specific to where your gaps in studying are. That corresponds to any of the practice questions I post throughout the week, but also the stuff that I do on Sunday night NPTE night school. Big three is most important. You're absolutely right. But if you don't, I mean, if you don't know your rule of nines, that is a chip shot question that you should be getting. If you don't know your ADA accessibility questions, that's a chip shot question you should be getting. And if I get a chip shot question easy, then maybe I can miss one more cardiopulm or one more MSK question. I don't have to be too worried about it. So I agree. You definitely want to know your systems, like your big systems. But if you just don't study the other stuff, there may be one or two or three questions that you missed that if you had just gotten that ADA question, or you had just gotten that rule of nines or wound questions, or if you'd gotten appropriate assigning appropriate ADs or something like that, and you missed it, then that would suck if you were like 5 points off from a 600, right? So I agree, the big stuff is super duper important, but don't sleep on that small stuff, because if you miss one or two questions and that's what kept you from getting licensed, that's going to be incredibly frustrating for you. So, sorry, I talked for a long time. Non-systems and cardio, okay. I studied minimums and got all maximums for ADA. Oh, that stinks, Austin. I'm sorry, dude. Usually with that, when I was studying for my boards, I just wrote that crap in tables, and me and my buddies would just drill it. So I'm a super big auditory learner, and I had buddies that were really kinesthetic, and so they wanted to write everything down on boards, on like whiteboards, and I was cool with that, with the caveat that like when we got done, I was able to like talk it out loud with them, because the auditory learning is where I really thrive. And so I would just say do that, because even if you're not super kinesthetic, like just writing it out, research has shown that it's going to stick with you so much better than if you just like type it or read it, right? Okay, let's go on to question number 10. This is our final question, and then I've got I'll leave some time at the end to just go over any questions. If you guys have any questions about tips for the MPTE, or study tips, or anything like that. And so let's just jump into our last question. Which intervention is most appropriate during early mobility for a patient hospitalized with acute decompensated heart failure? A, high-intensity interval training. B, bed rest until discharge. C, low-intensity activity with frequent monitoring. Or D, Valsalva maneuver during transfers. Let me read it one more time. Which intervention is most appropriate during early mobility for a patient hospitalized with acute decompensated heart failure? A, high-intensity interval training. B, bed rest until discharge. C, low-intensity activity with frequent monitoring. Or D, Valsalva maneuver during transfers. Skylar has answered. Thank you, Skylar. Let's see. Lily, low answered. Northgate, Trent, user, Austin. Very good. I'll give you guys some more time. No, guys, don't be nervous about getting these things wrong when I ask you questions. Go ahead and throw out the answer. It's not going to hurt anything to just, even if you're guessing, right? I just want to see what you guys know, and you guys want to see what you guys know, right? And so if you guys get it wrong, I'm not going to shame you for it. I'm just going to tell you why the wrong answer is wrong and why the right answer is right. So let's go ahead and talk about it. High intensity interval training for a person in acute decompensated heart failure. Are you nuts? That's a terrible answer in the acute stage. Maybe once they get to outpatient therapy, HIT would be a good thing, right? Because we want to really build up their cardiac endurance. But that's a terrible thing to do in acute early mobility for acute decompensated heart failure. Bed rest until discharge. I would, well, first off, the doctor is going to be the one that orders bed rest. We aren't going to be able to say like, no, you're not moving until you get out of here. Because if you're in the acute setting, they need you, the hospital needs you to make a recommendation, right? Never D. A is too soon. B doesn't give any room to progress to transition home. Yeah, you're absolutely right, Lou. So how are we going to get, if we have them on bed rest until discharge, how are we going to know where we're supposed to recommend they go to a SNF or home with outpatient therapy, or to inpatient rehab? So I again, we would never be the one to make this call to like put a person on bed rest, but that's a bad idea. You're going to have a bad time if that's your recommendation. C, low intensity activity with frequent monitoring. That sounds incredibly safe, which is exactly what this question is asking. What's the most you should do but is still safe when you're working with someone that's got decompensated heart failure? So that looks pretty good. Valsalva maneuver during transfers. That sounds like a terrible idea, right? Because why would you want someone to Valsalva? It's going to increase their intra-abdominal pressure, which is going to put more strain on their heart. It's going to increase, it's going to make them probably more tachycardic. It's going to increase their blood pressure. It's going to wear their heart out even more. It's going to make them have more decompensated symptoms. So never have anyone Valsalva. That's a terrible idea. So the answer is low intensity with frequent monitoring. Okay, so like I said, I will post all of these in pictures that you can just swipe through on my TikTok. I'll probably try to do that tomorrow. It may be tomorrow evening because I'm grading. I've got my students have practicals, so I'm an adjunct faculty at a PT school right now, and they've got practicals tomorrow. So I'll probably won't get to posting these until the evening. It is definite stairway to heaven. That's funny. What is the rule of nines? The rule of nines is when you're trying to decide what percentage of a person's body has been burned, right? So like this all is 9, like the whole arm is 9%, the head is 9%, the front of the body is 9%, the back is 9%, and then each leg is 18%, right? And then genitalia is 1%. So I got a comp on Tuesday. Yeah. So the rule of nines is like basically if you get a question that's talking about like you get a patient that's admitted because they experienced third-degree burns and they've got the anterior arm has been burned, their back has been burned, and their face has been burned. What percentage roughly has been of their body is burned? And so that's the rule of nines. I mean, of course, it was in our wound care book in school, but when I had my score builders, which is what our school bought, they don't buy that anymore, but that's what my school bought or had us buy, and it goes through rule of nines. Northgate, nice job. That wasn't one of the questions, but it's a good one to practice with because, like I'm saying, if you just know that stuff, all you got to do is be able to add, right? If you can break down, like, well, the front of the arm, the whole arm is 9%, right? So if only the anterior section of the arm, that would be 4.5%, right? The back would be 9%, and then the face, the head would be 9%, right? And so, if those are just chip shot questions, dude. No calculator. You don't need it, man. Nines are easy, man. Right? 9, 18, 27, 36, 45. Everything adds up to 9. So, yeah, absolutely right, Northgate. So you don't want to be, I mean, you don't want to get that failed thing and then you get your results in the mail and you were like 5 points off from getting a passing score, right? Because you just didn't have, you didn't know the stuff that I think is stupid, like which medication should you have used for iontophoresis, or which pulse, which frequency should you use when you're ultrasounding for subacromial bursitis, right? Are you from the USA? Yes, I am from the US. I grew up in Arkansas, and it takes, so we say 7 years because you have to get your bachelor's degree in anything, and as long as you get your prerequisites so that you can apply to PT school, then you're in PT school for 3 years, right? So it takes 4 years of undergrad and then 3 years of grad school. In the US, the entry-level degree to practice physical therapy now is a doctorate. So, yeah, Ionto gives me a headache, and so does Farm. Yeah, Ionto is dumb, but I just came up with these absolutely stupid mnemonics. So, like, potassium chloride is what you use. Oh, gosh. It was like K keloid. So that's how I remembered it, because like they use that for like keloid scarring to like help with keloid scars. And so I just remembered that potassium chloride, K, and then I said keloid scars. And so I just had stupid ways of remembering it. Lidocaine is for analgesia. I feel like that one's kind of an easy one. But there's some other stupid things I just came up with so that I could just remember. But yeah, are there any other questions about tips about studying or my routine on here? I'm going to try to throw in some more cardiopulm and non-systems questions in next time per the request of someone else, but I'd be happy to do any amount of that stuff throughout the week as well. If you guys follow my page, I'll regularly post practice questions. So that way you guys have some content throughout the week as well. And we're not just waiting till Sunday. Skylar, yes, I do this every evening. This is the third NPT night school session that I've done, but I'm trying to get a routine of Sunday nights, 8 p.m. Central Standard Time in the US. And I'll go through 10 practice questions and I'll just gear it around what you guys want to know. Other systems heavy. Okay, so third, I missed the last one. Yes, I'm sorry, Fibula. Were you there for my first one, Fibula? Your name is so familiar. You were at the first one. Yeah, because I thought your name was funny. Yeah, this is the third one. Yeah, this is the third one. So yeah, I'm gonna do it every Sunday, 8 p.m. You're gonna see me looking super awkward as I wait for people to come in, and I'm just gonna start. Maybe I'll come up with some good jokes. So as you guys are sort of like falling into the room here, I'll just like have some stupid jokes. Ooh, there was a good one though that I had just the other day. Oh, it was this. It's so crows are having a hard time. Ornithologists are finding out that crows are having a harder and harder time communicating with one another, and they're becoming nonverbal. And scientists are scrambling to find the cause. CAWS. So that's my level of jokes. So if you guys don't like dad jokes, then you're not gonna like my jokes at all. But all right, guys. If you guys don't have any other questions, yeah, you're welcome, Trent. Lou, thanks for the pity laugh, Lou. If you guys don't have any other questions, then I'm just going to sign off. If you guys have questions that come up throughout the week, feel free to direct message me. And just know, like I said, I post either daily or every other day some NPTE practice questions so that you guys have some content between Sundays. If there's anything you want me to do specifically, I'll try to do some non-system stuff. I'll do some cardiopulmonary stuff throughout the week as well. But you just feel free to shoot me messages if you're like, hey, can you do some practice content? Or if you want me to teach something like, hey, I don't feel like I really understand why that was a good answer for, like why COPD was the answer for that, then I'd be happy to put together like short, like 3 to 4 minute lectures of like, well, why was that the answer? So, all right, guys.